Our second speaker this morning is Dr. Callie Zhou, who is also trained at UCSF and at USC. This may be a pattern we're used to seeing here, Nora. As Nora resuscitates USC back to its stellar position as the best liver center in LA, but UCLA is still good at tennis, so no worries, Steve. You can tell I'm not biased to where I trained. Anyway, Callie's going to give us an update on viral hepatitis.
Thank you, Dr. Parkers. All right, good morning, everyone. I'm delighted to be here to present some high-yield abstracts from this year's liver meeting related to viral hepatitis. Okay, here are my disclosures. So Dr. Zhou earlier gave us an outstanding overview of the cure of HBV. Thus, I will shift this talk away from novel therapies and focus on highlighting abstracts grouped around three main themes. The first will be elimination and epidemiology and viral elimination efforts. Secondly, viral hepatitis-related liver cancer. And lastly, considerations around currently available treatments. So diving right in with epidemiology and elimination. We start with characterizing the cascade of care for HBV, importantly establishing a baseline in 2019 in order to know where we were prior to the pandemic, but also for future evaluation of the impact of COVID-19 on these elimination efforts. This study estimated the global cascade of care for HBV in 2019 and also quantified our progress related to mother-to-child transmission using prevalence of HBV among 5-year-olds as proxy. This study team from the Center for Disease Analysis used a previously developed progress Markov model, which incorporates data from national registries and country sales reports. They developed 166 country-specific models, of which 94 were evaluated by country experts via the Delphi method. So the primary finding was a global surface antigen prevalence of 3.6%, which is equivalent to 274 million infections. Of these, 12% had been diagnosed by 2019, 30% were potentially eligible for treatment, of which 8% were on treatment, which actually met the WHO goal of 5 million on treatment by 2020. For HBV diagnosis, however, no continent achieved the 2020 target of 30%, though Europe did come close. Africa came in at 5%, and the road to the 2030 target of 90% diagnosed is still quite long for most countries. So 90% of all HBV-treated cases came from 8 countries, including China, Korea, and Japan leading the way, with the USA with 5th. Now, looking at 5-year-old prevalence, they did find a disparity in prevention of mother-to-child transmission, where Asia accounted for 69% of all infections, yet only 33% of infections in 5-year-olds. Vice versa, Africa had 65% of 5-year-olds, 5-year-old prevalence versus 26% of all infections. So we clearly need global increases in both screening and treatment for HBV, but we also need to focus our efforts on preventing mother-to-child transmission in lower middle and low-income countries. Now, shifting to HCV, countries have been making consistent progress toward HCV elimination efforts prior to COVID-19. This study estimated progress up until the start of the pandemic in 2020. Modeling was done similarly to HBV, incorporating data from both published and unpublished literature and consulting with country experts. The Markov model they used here was the HCV BRIGHT model. They modeled 110 countries with input from country experts in over 70%. Now, the global prevalence of viremic HCV infections was estimated at 0.75% in the beginning of 2020, equaling 59 million infections, which is 7 million less than their estimates in 2015. 9.4 million were treated between 2015 and 2019, more than a third of which were from Egypt due to these countrywide governmental programs. And on the map on the right, you'll see that prevalence remains highest in Eastern Europe and Central Asia. And you'll see the change in prevalence between 2015 and 2020, with most countries not experiencing substantial changes. Highlighting the United States, our incidence has actually dropped into the lowest prevalence range of 0 to 0.6%. And there was a marked drop for Egypt from over 2.8% prevalence down to under 0.6%. Now, globally, there is still work to be done, as less than a quarter of active HCV infections have been diagnosed and only 1 out of 10 treated. Now, how has COVID-19 potentially impacted elimination? So models can serve as a guide, but aren't always reflective of real-world conditions. Here, initial results were presented of a prospective web-based survey to compare clinical practices before and after the start of the pandemic. This survey was sent to EASL members in centers in Europe, as well as experts worldwide. It opened in May of 2021, and it's still ongoing. The main questions assessed were change in outpatient consultations and referrals, initiation of treatment, and testing as a proxy for new diagnoses, both before COVID-19, so in 2019, and then after the start of the pandemic in 2020. So these are results as of July, so only 2 months into the survey. There were 37 centers from 5 continents that responded, half of which were from Europe. And these were notably primarily referral centers, not community clinics. And COVID is expected to impact these centers, as all but one treated COVID-19. As expected, there was a decline in all metrics before and after and during the pandemic, with a 30% and 45% decrease in HBV and HCV consultations, respectively. Surface antigen testing had dropped quite a bit, while HCV RNA testing only slightly. In terms of treatment on the right, 68% of centers reported an over 50% reduction in new treatments started for HBV, and 58% of centers reported over 50% reduction in HCV treatment. So clearly the pandemic has impacted the care of chronic viral hepatitis, which may in turn impact elimination and the morbidity and mortality of the individuals infected. Now, I thought this abstract was an interesting thought exercise. Would it be cost-effective to treat all surface antigen positive, regardless of HBV DNA or ALT parameters? So again, we have the progress model, but now populated with US-specific economic inputs. They used a base annual treatment cost of $5,400 based on US sales data, and they looked at 3 scenarios in this model, all compared to current standard of care. So the first was to treat everyone by 2030, so all surface antigen positive. The second was to treat everyone, but at a reduced treatment cost of $2,000 by 2025. And lastly, they were interested in the price point by 2025 that treating all would potentially be cost-saving by 2050. So here are the results. In the first scenario, treating all at current prices, so $5,400, becomes cost-effective in 2037 with an ICER of $41,900. And secondly, if drug cost lowers to $2,000, treating all becomes cost-effective earlier in 2025. And if we treated all at a price point of $750, treatment would be cost-saving by 2046. So they made the case that treating all would lead to reductions in new infections, HCC, and cirrhosis, and potentially avert deaths in 157,000 patients, keeping in mind that the assumption here is that everyone is being diagnosed. I think importantly, the study provides, at minimum, a good case for reducing current drug costs. Lastly, the study provides a look into the burden and makeup of HDV infections in the US through the framework of inpatient hospitalizations. So the authors used the NIS database between 2010 and 2018, and they compared hospitalizations for patients with hepatitis D only versus those with hepatitis B, but not hepatitis D. And these were identified using relevant ICD-9 codes. Social-demographic and geographic factors were compared, and factors associated with in-hospital mortality were examined. Their main finding was a very low prevalence of hepatitis D among hospitalized patients with HBV at 0.6%, which is lower than what we would expect based on general prevalence estimates. The average annual hospitalization rate for HDV had decreased slightly between the ICD-9 and ICD-10 eras. The much smaller HTV group were more often male, Hispanic, and hospitalized in the northeast region of the United States. They also had more ascites and portal hypertension, but inpatient mortality was the same at 4% in both groups. Among those with HDV, age over 65 was associated with higher mortality as well as concurrent alcohol use. Given that this is administrative data based on ICD-9 codes, I think some of these findings may reflect differences in coding and should be viewed with some caution, but I think it also highlights that HDV remains underdiagnosed in the United States. So the key takeaways here are that elimination targets remained elusive for both viruses prior to COVID-19, with the pandemic expected to have a substantial negative impact on global progress. To support elimination goals, we do need some innovation in screening and treatment, as well as some lower drug costs. And HDV is coming increasingly into focus with new treatments, and the burden of disease in the United States is still unclear. We do need better data, and we need more testing. So moving into topics related to liver cancer and viral hepatitis. So globally, viral hepatitis accounts for over 2/3 of HCC cases. Immunotherapy, so Tezobev, is currently first-line therapy for advanced unresectable HCC. Thus, the immunologic microenvironment is of significant interest. And this intriguing study compared the immune landscape of HBV-associated HCC with HCV-associated HCC. They took 11 patients with HBV and 9 with HCC, performed RNA sequencing on both tumor and normal tissue, and it looked at a curated list of immune-mediated genes, alpha SMA, CD3, CD4, CD8, and CD20, with immunohistochemistry. So first off, they found that HCC is associated with a predominant gene downregulation for both viruses. The types of genes involved were slightly different. For HCV, there was predominant dysregulation of genes involved in T cell activation and oxidative stress, compared to cell cycle regulation control for HBV. And then looking at patterns of immune cell infiltration on histology on the right, you'll see they identified two distinct patterns. So all HCV HCCs were cold tumors, which had no or minimal expression of immune cells. However, 7 of 11 HBV tumors were also cold, but there were 4 hot tumors that had abundant immune cell infiltration and expression of genes in both the innate and adaptive immune response pathway. And so they concluded that the distinct molecular signature and immune landscape for viral hepatitis-related HCC may ultimately allow us to better understand pathogenesis, but also select patients for immune-based therapies. Now we have an updated study using VA data on the ongoing controversy around HCC risk in patients treated with Tenofovir versus Entecavir. So a prior VA study had shown no difference, but this was possibly limited by 1, misclassification of HCC, which was based on ICD-9 codes in that study, and 2, incomplete measurements of drug exposure. So this study included all surface antigen positive updated to 2018 who had filled at least 1 prescription. Here, the outcome of HCC was identified using a central cancer registry, as well as ICD-9 coding, but then manually confirmed, which actually eliminated 22 cases misclassified by ICD alone. Drug exposure was analyzed in 2 ways: time updated to current drug exposure, and the cumulative duration of exposure of those drugs. Propensity score matched Cox regression models were performed. So they included 3,735 patients, about half on each drug, with an expected VA demographic. Now, they identified cirrhosis by ICD-9 or FIB4, and they found similar rates in both groups. The Entecavir group did have slightly higher E antigen positive and HBV DNA at baseline, and the mean follow-up time was 4.1 years. So looking at the table, you'll see the number of HCC cases in the model results overall, followed by the duration of drug use and then current use. The incidence ratios for these groups did overlap for Tenofovir and Entecavir, but there was a trend towards lower risk for Tenofovir in both time-updated models that reached significance when considering total duration of treatment, with a risk reduction of 11% on Tenofovir. But whether this possible small lowering of risk warrants changes in clinical practice remains to be seen. Now, we're all aware of new HCC developing in patients after DAA treatments, but the medium to long-term risk is less well described. This prospective multi-center study seeks to shed light on some long-term HCC incidents. Consecutive patients were included from the Peter cohort, so these are cirrhotics treated with DAAs across Italy, who had at least 1 year of follow-up. Liver transplants in prevalent cases were excluded, and survival analysis was performed to identify factors associated with de novo HCC. 2,214 patients met inclusion criteria, of which 6.7% developed HCC over a median of 2.5 years of follow-up, equaling a calculated incidence rate of 2.8 per 100 person years. The proportion developing HCC, if SVR was not achieved, was 3-fold higher at 20% compared to 6% if SVR was achieved. In this cohort, 80% were actually diagnosed fairly late with BCLC B or C stage cancer. And factors associated with de novo HCC in multivariable models are highlighted in gray in the table, included older age, platelet count less than 150, albumin less than 3.5, as well as genotype 3. Now, baseline liver stiffness by elastography and change in liver stiffness after treatment differed between the two groups, with a smaller delta change in the HCC group. So this prospective study confirms that risk of de novo HCC persists long-term after SVR, and risk factors being more advanced cirrhosis as well as poor treatment response. Now, the incidence of HCC of 2.8 per 100 person years from that Peter cohort would be well above our current threshold for HCC surveillance of 1.5. Now, this study sought to really reevaluate the cost-effectiveness thresholds by which we decide to perform HCC surveillance, focusing first on the post-DAA treatment population, who are expected to have lower competing risks after cure, and is definitely a growing patient population in the United States. So they used a microsimulation model, which accounted for these competing risks: rate of HCC progression, adherence to surveillance, and updated treatment costs, options, as well as utilities to present day. They also selected a lower willingness to pay threshold of 100,000, previously 150. So essentially what you see here on the left is that the ICER for the old incidence threshold of 1.5 is now very cost effective. And at the current willingness to pay threshold of 100,000, HCC surveillance is cost effective at a new threshold of 0.4 per 100 person years, well below the current threshold. Now this is a model, so it's important to consider what happens when your model inputs are changed. In their probabilistic sensitivity analysis, in which the distribution or range of model inputs are sampled and then considered in repeated simulations, they find that the range of possible incidence thresholds all remain below the current recommended threshold of 1.5. So this modeling study suggests that we may need to reconsider the incidence cutoff for HCC surveillance among treated HCV patients, but potentially also that for all cirrhotics. So in summary, the hot and cold immune landscape in viral hepatitis-associated HCC may have future implications for diagnosis as well as treatment selection. When treatment duration is considered, Tenofovir may lower HCC risk compared to Entecavir, but jury is still out on clinical impact. HCC surveillance should continue long-term in HCV patients with cirrhosis after achieving SVR, and surveillance may be very cost-effective. So lastly, we will turn to some abstracts on current treatments. So this first study is an update from the RETRACT-B cohort, which last year presented on increased frequency of surface antigen loss in Caucasian compared to Asian patients after NA withdrawal. In this abstract, the RETRACT-B authors examined long-term virological and biochemical response, focusing on the patients who did not achieve desired outcome in the first year. So in this retrospective international multi-center study of e-antigen negative virally suppressed patients who discontinued NAs over about 20 years, they excluded anyone with S-loss, retreatment, or decompensation in the first year, but allowed everyone else to have fluctuations in their HBV DNA in ALT in that first year. Then they used survival analysis to examine outcomes after the first year, focusing on sustained remission, which they defined as an HBV DNA less than 2,000 and ALT less than 1.5 times upper limit of normal. 945 patients were included. The majority were male and Asian. 62% were on Entecavir, 29% on Tenofovir. So at 4 years off therapy, 9.7% had achieved surface antigen loss, and 36% were retreated. This dropped to 2% and 43% respectively among those who actually did have a virologic and biochemical relapse in the first year after withdrawal. The figure on the right shows that the primary outcome of sustained remission and or surface antigen loss was 44% at 2 years, dropping to 30% at 4 years, while frequency of retreatment increased more than the frequency of surface antigen loss over time. And the predictors of sustained relapse or surface antigen loss were Caucasian race, e-antigen positive at start of treatment, a low quantitative surface antigen, and no relapse in that first year. So they conclude that those with relapse in the first year of withdrawal who do not experience surface antigen loss potentially may benefit from earlier retreatment. This abstract is also an update from last year where initial data on the safety of TAF for mother-to-child transmission prevention was presented. This study further evaluates the safety and efficacy of TAF in pregnant women with active CHB, so not solely a preventative measure, and compared it to those on Tenofovir. This was a multi-center prospective study in China, including pregnant women with either a new diagnosis of active CHB or switched from a different drug. All infants received standard birth dose vaccine and immunoglobulin. The primary endpoint was adverse events, and the secondary endpoint was viral suppression and mother-to-child transmission rates. So 218 active CHB mothers were screened. 69 treatment-naive chose TAF, 63 chose Tenofovir. 34 switched to TAF, and 41 switched or continued TDF. Approximately 100 infants were born to each group. Now, looking at effectiveness, there was no difference in effectiveness between the two groups for both viral suppression, ALT normalization, as well as E antigen seroconversion. There were also no cases of mother-to-child transmission at 7 months postpartum. In terms of adverse events, there was one induced abortion for fetal cleft lip and palate at week 23 of pregnancy. However, the developmental process of cleft lip and palate are completed by 6 to 10 weeks of embryogenesis, and TAF was started at week 12. Thus, the authors strongly doubted the role of TAF in this infant. There were no treatment discontinuations due to adverse events, and infant development was similar and comparable to national standards. So in this Chinese cohort, TAF had comparable safety and efficacy to TDF for treatment of active CHB in pregnancy. Now, accurate estimates of HBV reactivation risk in patients with rheumatoid arthritis, for example, on immunosuppression with resolved CHB are still needed. So this is a retrospective study performed in Taiwan in this population with comparisons by biologic drug class. So they screened 1,937 patients, of which about 1,000 had resolved HBV and half received a biologic. Patients didn't receive prophylaxis as it was not reimbursed by national insurance. So the primary biologics compared were anti-TNF, abatacept, which you might recognize under the brand name Orencia, and prevents antigen-presenting cells from delivering a co-stimulatory signal, rituximab, and tocilizumab. The primary outcome was reactivation, which they defined as reappearance of surface antigen, which they monitored every 6 months. So there were 3 cases of reactivation on anti-TNF, 6 on abatacept, and 18 on rituximab. The likelihood of reactivation with anti-TNF as reference was 15-fold higher with abatacept and 36-fold higher with rituximab. Receipt of steroids was slightly higher in the reactivation group, and receipt of more than one biologic was much higher. Notably, the cumulative incidence of reactivation was highest in those who were negative for surface antibody titers. Based on these results, the authors outlined a potential algorithm for use in clinical practice. So all patients will receive NA prophylaxis for rituximab. For abatacept, prophylaxis is stratified on surface antibody titers, given significantly higher risk of reactivation with low or undetectable titers. And they recommended monitoring for all other biologics, including anti-TNF. So shifting to HCV, while DAA therapy has certainly simplified treatment algorithms with exceedingly high response rates, there remain a small minority of patients who have not achieved SVR despite multiple lines of treatment. The current recommendation for these patients who failed soft-Velvox is a 4-drug regimen of sofosbuvir, glecaprevir, pabrentasvir, and ribavirin for 16 to 24 weeks. So this retrospective cohort study from 2 centers in Northern California sought to characterize and describe experiences of a larger cohort of these treatment failures who ultimately received this regimen. Efficacy was defined as SVR12. So 12 patients with soft Velvox failure went on to receive soft Glepib and ribavirin. The median age was 66, over 80% were male and white race. 2/3 were genotype 1A and 1/3 genotype 3. So 2 patients had a history of transplant, 3 had HCC, half received weight-based ribavirin and half 600 milligrams per day, and no patient required EPO. There were no treatment discontinuations or hospitalizations. So looking at the table of patients, you will see that most had received 2 prior regimens, most had 1 or more mutations detected, but most importantly, all patients achieved SVR at 12 weeks post-treatment. So the high efficacy and lack of safety concerns of this salvage regimen is highly encouraging for our most difficult to treat HCV patients. Lastly, I wanted to present some exciting early real-world results of patients in France with chronic hepatitis D treated with Bulevirtide, a first-in-class entry inhibitor for HDV infection, which received conditional approval in Europe in 2020 and is currently being evaluated by the FDA for approval in the United States. So Bulevirtide is delivered subcutaneously at a dose of 2 milligrams once a day. Eligible patients in this French study had access to the drug over 1 year. These patients had either compensated cirrhosis, F3 fibrosis, or F2 with persistently elevated ALT. Half the group received Bulevirtide alone, so monotherapy, and half had addition of weekly PEG interferon alpha. Treatment regimens and all modifications were at the discretion of their treating physicians. The primary endpoint was the same as clinical trials, with either undetectable HDV RNA or greater than 2 log 10 decrease from baseline. This was a per-protocol analysis, and 12 patients that discontinued PEG interferon were not analyzed. The mean age of patients was 41, and 62% had cirrhosis. So looking at HDV RNA, there was a significant on-treatment declines in both groups, those steeper in those on interferon. At 1 year, 39% on monotherapy versus 85% on combination therapy had undetectable HDV RNA levels. Mean ALT also improved in both arms, but more achieved normal ALT on monotherapy. So overall, 68% on monotherapy versus 94% on combination met the primary endpoint of undetectable HDV RNA or 2 log 10 decline. Monotherapy patients were slightly more likely to achieve both virologic and normal ALT endpoints. Grade 3 to 4 adverse events occurred in about 10% in both groups, half of which were liver-related, including ascites, HCC, and varicose bleeding. Nearly all patients had asymptomatic elevations in serum bile acids, which is an expected effect of the drug mechanism. And no patient had surface antigen loss in both arms. So results of this real-world study were similar from those seen in clinical trials. So some concluding thoughts. HBV patients who do not achieve desired outcome in the first year after withdrawal therapy have a much lower chance of sustained remission, and earlier retreatment can be considered. TAF is safe for both the prevention of transmission as well as the treatment of active CHB in pregnancy. Prophylaxis against reactivation in core antibody positive should be considered for abatacept in addition to rituximab. And finally, in real-world settings, we have a good option for soft valve VOX failures for HCV and potentially soon an effective and well-tolerated treatment for HDV. All right, thank you for listening, and thank you to the organizers for inviting me today.